Welcome to my operation theatre. Today you will be seeing a procedure known as kyphoplasty. Kyphoplasty is basically a minimally invasive spine stabilizing procedure. This is done to treat painful vertebral compression fractures that are most often due to osteoporosis. Now, osteoporosis, as we know, is a problem in elderly people where the bone density itself falls, and sometimes it falls to such an extent that even trivial falls like a fall in the house, a fall in the bathroom, or a bout of sneeze and cough can cause a fracture in the spine. Now, usually fractures will heal over time, and most osteoporotic compression fractures will also heal over time with a little bit of bed rest and medicines. But there are those that will not, and this stands at a percentage rate of around 20 to 30% patients. So 20 to 30% patients will typically not heal as we would expect a normal patient to, even after physiotherapy, even after bed rest, even after medicines. And in those patients, we would discuss a procedure known as kyphoplasty, or sometimes another procedure known as vertebroplasty. So here what you're seeing right now is our patient is lying down. He's lying down on his stomach. He's comfortable. This is under local anesthesia, so right now he's not received anything. My team, you can see my assistants, made the area sterile, the part of the surgical area, and we are draping the patient. Our anesthetist is on standby. He will give inhalational anesthesia so that the patient can be relaxed while the procedure is going to be performed. So coming back to the vertebral fracture itself, as I said, most of these fractures will heal with rest and medicines, but some don't. Now, in those that don't, continuing bed rest comes at high risk. So there are something in medicine known as problems associated with recumbency, which means keeping someone in bed rest for too long. And these problems are many. I'll name a few for you. One is bed sores. So keeping an elderly person on bed rest for a long time can lead to bed sores, and these are very difficult to manage. They develop urine infections, chest infections, malnutrition. And one of the most important things that happens to the elderly when they stay on bed rest for a long time is severe muscle wasting. And unlike the young, who once they start walking around, their muscles tones will come back and the muscle strength will come back. In the elderly, once muscle strength is lost, it's very difficult to bring it back. So you just saw me speak to him. I've assured him that we're going to be doing this procedure, and is he comfortable? Once he is comfortable, he gives the thumbs up that we are good to go ahead, is when we're going to start. So you can see everything is ready. The machine that's being brought in is our intraoperative X-ray machine. We use this to localize exactly where the fracture is, and it's going to help us make the access into that fracture vertebra. So the goal with this is essentially to stabilize the fracture vertebra. So in a kyphoplasty or a vertebroplasty, what is done is an access is made into the vertebral body, which is fractured, and then through that access, cement is injected into the vertebra. Now that cement will then stabilize all the fracture pieces and help that vertebral body behave as one unit again. And this itself reduces the pain and allows them to be mobilized early. The whole goal of this surgery is pain reduction and early mobilization. Once they are pain-free or the pain reduces, they can turn in bed, they can move, they can start walking around. So this patient itself, he's given us all permissions required to shoot this and to use this video and to publish it on social media. So coming to this patient itself, he's an 80-year-old gentleman who suffered from a small fall at home, and he had severe back pain. Back pain was to such an extent that he couldn't turn in bed, he couldn't sit up, he couldn't move around, he couldn't go to the washroom, could not participate in self-care, and he was struggling. His day-to-day activities had become a struggle, and he had become dependent on other people. In him, medicines and bed rest did not help. And so once we confirmed the diagnosis, I told him that it's a daycare procedure. You can go home the next day. Let's do this. We'll get you moving faster. And he agreed. So he's lying down on his stomach. With the machine, I can see, you can see through the, on the image there, that we've located the vertebral body which is fractured. And now what I'm hammering in is known as a Jamshedi needle. This is what we use to access the vertebral body. Now, the whole skill set in this surgery lies in getting those Jamshedi needles into the right spot, so that we can do this procedure with less risk. So these Jamshedi needles go in under local anesthesia. I've already injected, and a small nick to allow them to go in. Once we're at the spine and we're happy with the location, then we'll slowly hammer it in. So I've already discussed the indications of this procedure, which is a painful fracture which is not healing, and a patient who's been on prolonged bed rest. Now coming to the risks of the procedure. Now there is no procedure, let alone spine surgery, there is no interventional procedure which comes without risks. So this procedure, even though the risks are low and acceptable, also comes with risks. And the risks are primarily cement leakage. Now once we have accessed the vertebral body, once we've cannulated the spine, then through that cannula, I'll be showing you step by step what is done, and eventually we'll be injecting cement in to stabilize it, to stabilize the fracture pieces. That cement will hold everything together and stabilize the fracture body. So right now what you see is we have cannulated the vertebra, we have gone right up to the vertebral body which is fractured. I'm making sure that our location is absolutely perfect before we proceed to the next step. So coming back to the complications, one possibility is cement leakage, since cement is always injected in the liquid phase. And that vertebral body is close to very important structures. In front are the great vessels, behind is the spinal cord, and in the vertebra itself are vascular channels that go to the heart and lungs. So if the cement leaks in front, it can fall on these great vessels, causing injuries. It can leak back into the spinal canal, causing spinal cord injuries, and it can leak into the blood vessels, going to the heart and lungs, causing what is known as cement embolization. Now, to reduce this risk, we inject the cement in a particularly semi-solid state so that it doesn't leak anywhere. And what I'm doing now is the second thing that can be done to reduce it. So this is where a kyphoplasty and a vertebroplasty is going to differ. Many of y'all may be offered vertebroplasties. This is where the procedure differs. Once the needle is in, like you're seeing right now, I took that original Jamshedi needle out and I'm putting in another one. This has a wider bore, a wider hole, which will allow us to then put in a balloon, expand it inside, and create space for the cement to go and get localized in the vertebral body. So right now I'm exchanging the second Jamshedi. I've put a guide wire in, and I've bought back a cannula which has a bigger hole. As you can see, even though it's being done under local anesthesia, our patient is very comfortable. He's calmly resting and he's not wincing much. So typically when we tell patients, we're going to be doing a procedure under local anesthesia, they are very scared. They imagine a lot of pain and it being very difficult to undergo the procedure. But in reality, it's more like this, where patients are calm, they're resting, sleeping, we are going about our work, there's not much disturbance. Sometimes they chat with us, sometimes they want to see. If they want to see the procedure, then we put the screen in front of them. So right now both the cannulas have been exchanged for wider bore, and what I'll be bringing in is a balloon. And this is a medical grade balloon. It will be pushed into the cannula, into the spine vertebral body which is fractured, and then it's inflated. And once it's inflated, we'll be able to see on the X-ray machine that it's how it's expanding. And the space it creates is the space in which the cement will be injected. So coming to the, so now you can see the balloon is being prepared. And the balloon is pushed in. And now coming back to the image, look at the image on the X-ray machine, on the TV, and you'll see that the balloon is being expanded. Alright, this entire part of this procedure has to be done perfectly. So to make sure that the balloon is in the perfect location before it's expanded. So once I confirm that the location is good, we're now going to expand it slowly. So that's the gauge and the machine in my hand, which is being rotated. And as I rotate it, it pushes radio opaque dye into the balloon, which can be seen on this X-ray, so that we can see what's happening inside. So now you can see the balloon is expanding and creating space. And once we reach optimal expansion, this part is done. We will deflate the balloon and take it out. Alright, now once the balloon is out, the next step is to just prepare the cement and inject it into the vertebral body. So we're going to advance this part and speed it up, because we just wait around for 10 minutes while the cement is being prepared. And yeah, so this is right now at 10x speed, we're waiting. And once the cement has reached the right consistency, it's become thick enough to be injected and not too liquid to leak here and there, that's when we're going to inject it into the vertebral body. So coming back to the other risks of kyphoplasty, one was cement leakage, the other is infection. Whenever we introduce anything into the spine, there is chance of bacteria getting introduced into the vertebral bodies. There are chances of that seeding happening in the operated area and infection resulting in infection, even though these are rare. Third is bleeding can occur and adjacent segment fractures. Now, as I said, there is no procedure without risk, and we always weigh it out. Is the benefit to be achieved or to be acquired more than the risks that we are putting the patient in? And if it's yes, only in such circumstances do we offer the patient surgery. So when it comes to the outcomes of these procedures, these are generally considered lower risk and high satisfaction procedures. Patients typically, these are done on day care, which means patients can go home the same day or the next day after a short period of observation. The pain reduces by 70 to 80% almost immediately, and that is considered a great outcome, because when the pain reduces, these patients can start walking more, walking around the house, participating in self-care. Another important part is, since they're osteoporotic, is to establish their osteoporosis by doing a DEXA scan. And once that is done, then starting osteoporosis management, so that it prevents them from having further fractures in the other vertebral bodies. So right now you can see that we're injecting the cement in. The cement is the black colored fluid that's coming out of the cannula and going into the vertebral body. This cement stays in permanently. It's medical grade cement known as bone cement. Okay, so for the rest of this video, there's nothing much else to be done here. We're gonna wait. Once the cement is set, we're gonna take the cannulas out and I'll let you watch the rest. You can see him the next day of surgery. He's mobilized himself. He's out of bed. After many days of staying in bed, he's now comfortable and out of bed. And he's walking around and ready to go home and resume his normal activities. And I hope this video helps you. As you can imagine, there's a lot of production value in this. We need a big team, one that records, edits, helps us create all of this, patient permissions, and I hope you appreciate it. You can consider subscribing, liking this, sharing it with others who may have been prescribed a similar procedure. That would help this channel greatly. So at the end of this video, you'll see him give a little bit of his feedback on the procedure, his experience of it, and him walking. I'll see you at the next video. Stay fit, stay active.
আপনার বয়স?
আমার বয়স 79।
হ্যাঁ।
ভেলে চাকরি করি। ভেলের ইয়েতে আমি উপর থেকে আমি এসেছি। আমি ডক্টর সুমায়ু দত্তের কাছে ট্রিটমেন্ট নিয়েছি। আমি স্পাইনাল কর্ডের স্পেশালিস্ট। এর আগেও আমি অপারেশন করেছি। আমি উঠতে পারতাম না, চিৎকার করতাম। হ্যাঁ, স্পাইনাল কর্ডে একটা পেন হচ্ছিল, ভেঙে গেছে। তার ইয়েতে আমার উনি যে ট্রিটমেন্ট করেছে আমাকে ডাইরেক্ট বলে দিয়েছে কীভাবে করবো। নিডল দিয়ে দেখিয়েছে, কেউ দেখায় না, দেখিয়েছে নিডল দিয়ে, প্লাস এদিক দিয়েও দেখিয়েছে, ইনজেক্ট করেছে, পারমানেন্ট সমস্ত জিনিস করে। আমি তাও ভয় পেয়েছিলাম কত পার্সেন্ট, বলে আমি 90% হোপ দিচ্ছি। তা আমি এখন 90%, আমি 100% আমি মনে রেখেছি আশা করি বিয়েতে ভর্তি হতে।
বাহ। আর আপনার অপারেশন লোকাল অ্যানেস্থেসিয়া হয়েছিল?
হ্যাঁ, লোকাল অ্যানেস্থেসিয়া হয়েছে, নিজে হাতে করেছে। অ্যাসিস্ট্যান্ট ছিল, কাউকে করতে দেয়নি। নিজে হাতে আমি চেয়েছিলাম, নিজে হাতেই করেছি, এবং অ্যাজ এ গুড ডক্টর।